All right, thank you, Elizabeth, for letting me know that. I understand sometimes where are you? Where am I going? Um, so I understand people are still trying to get in. So we are on week 7. So now we're over the hump, right? And it's going to be starting to get a little bit more difficult with MedSearch 2, with the PEDS project, with the community project. It's going to be quite a bit. So just keep putting one foot in front of the other. You guys can do it. Just try to manage your times as best as you can. If you need to reach out, I'm available, whether it's Dr. Becker's classes or mine. I'm always here if you need help with content or dosage calculation. I'm actually very good at. So if you need me, please holler at it. This week, I'm going to just do a Kahoots. I'm not doing a PowerPoint. I'm going to do a Kahoots. I've actually gone through it actually earlier today and said, we need a little bit of changes. We need a little extra oomph here and here. Right now, you students are, weakened. So I think extra questions on the Kahoot always emphasizes those concepts I want you to know about. So we're going to do cerebral and endocrine dysfunction. Know that this week you do have a discussion question and you do have a case study due. You're going to do the one on endocrine. So any questions with any of that and what's going on this week? We will be doing our exam item analysis, as we call it. Actually, we all get together, discuss the question, see if there was any problems with the question, not written right, the answers were wrong, anything like that. We're going to be doing that Saturday about noon, so you should see your grades a little bit after that, because I know that's the first question you want to know. When am I getting my grades? All right, let's just do the Kahoots. So should we play a game? Dr. Becker's class and Bogart's class, and let's see who can win it. Now, this is all new information. Okay, so this is, and I know nobody's read to come into class and all this stuff. You're so concerned you've had other exams going on, so, I understand. So let's just see what we can do with this Kahoots today. I'm going to try to, as we go along, you'll start getting those little key, similarities, and you'll be able to answer some of these questions just because of that. Now, during this, if there's something you don't understand, you want me to stop, explain it in a different way, don't hesitate. It doesn't bother me. I don't get annoyed. I don't get upset. Ask. Make sure everybody has a name on their Zoom that is known by Fortis so that we make sure that you get proper attendance. First names don't work. Hannah, put your last name on that Zoom log for me, please. I don't want you not getting attendance because there is no second name. Or who are you? I don't know, okay? Got like about 50 something questions here. So we're taking just about an hour and then we'll be done for today. Let's get going. A lot of work to do. Cerebral or endocrine? Let's see which one. Growth hormone is administered by what route? So sometimes children are small and the rest of the family is big. And they want to take and use a hormone to help this child gain the maximum height they can. Now, the thing with growth hormone, it's the commitment like you are a diabetic. It's subcutaneous injections daily. So it's just like being a diabetic, right? And it usually goes on for a year or more. They stop giving the hormone when they stop growing less than 1 inch a year. So that's usually right around that pre-adolescent time. Highest priority for a patient diagnosed with syndrome of an inappropriate anti-diuretic hormone. Well, look at what the diagnosis is. Syndrome of an inappropriate anti-diuretic hormone against urinating hormone. Too much, inappropriate, too much diuretic hormone. That's what that means. And you can figure that out just from that. So when we're talking about fluid, now this week has a lot about fluid and fluid balances. How do you measure fluid? Intake, output, daily weight, okay? So your highest priority for when you have a child who is not urinating because too much anti-diuretic hormones being secreted is you're going to watch that intake and output. The other thing you're going to watch is daily weight, seeing how much weight they're gaining because they're not urinating. Which of the following are signs of an inappropriate anti-diuretic hormone? SIADH. What do you see? Well, we know the cause. It's too much hormone being secreted. What do you see when too much not urinating hormone? And if you have too much against urinating hormone, you're not urinating. So you're going to have a decreased urinary output. And you could have an increase in daily weight. What is important to cover when teaching the family about polypropyl? This is also called PTU. Well, PTU is something that's used when there's hyperthyroidism. Too much thyroid hormone is being secreted. The problem with this medication and another one that's given for too much thyroid hormone is that they tend to mess with the immune system. They cause leukopenia, decreased white cells, which means decreased immune system, you're at risk, fever, sore throat, or anything like that. Multi. An initial sign of diabetes insipidus. Now, this is the pituitary gland. Pituitary gland is two lobes. One has to do with growth. The other one has to do with fluid balance. So diabetes insipidus has nothing to do with blood sugars. I can't tell you how many nurses brought me a child into one of my ER rooms that said their history was diabetes insipidus and they took a blood sugar. And I asked them why. Because it has nothing to do with blood sugars. Diabetes, why they call it that, that's what, drives us crazy, the name. But it's diabetes insipidus is all fluid, too much fluid. So thirsty, 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 urinate, urinate, urinate. Now, because we're here right now, let's look at diabetes mellitus. What are the signs of diabetes mellitus? Well, again, it is too thirsty and urinating a lot. But if you think about diabetes mellitus, you have the inability to digest sugar. And your body's hungry for sugar. But your body still won't, no matter how much you eat, still is not going to have sugar. So that's why it's polyphagia. I'm hungry. I don't have sugar. My body can't use it. My body's still hungry, so I'm keep eating and eating and eating. So diabetes mellitus is 3 Ps. Okay? Very important concept there. Multi. What are the clinical manifestations of juvenile hypothyroidism? They're the same clinical things you see with adults, except one thing. There's no difference. A lack of hormone is a lack of a hormone. So the big thing about children versus adults and hypothyroidism is children need the hypothyroid hormone in order to be able to grow. So the one thing that we do every visit for a child is what? Everywhere, doctor's office, ER, urgent cares. We do a height and a weight. And one of the things that we do it for is to see, are they growing properly? If they are with hypothyroidism, we want to make sure, is the medication working? And we know that a couple different things. It's the height, it's the weight, and it's also cognition. Juvenile hypothyroidism can be detected at birth. This is another meconium ileus. Just like cystic fibrosis, this is another one, no stool. They would be checking for this and hypothyroid. And as we go on to week 8, there's one more thing that goes with it. The adult hypothyroidism, dry skin, sparse hair, constipation, cold intolerance. Yes, 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 for children. The difference is decreased growth because that's specific to children. Adults are done growing. A child has had a simple febrile seizure. What education would you provide the parents? I don't think a febrile seizure is too simple, is it? A seizure is a seizure, and it is scary. My oldest grandson had one on his mother, and she she flipped. And my son is a medic, was trained medic in special forces, so he knew what to do. She didn't. So any seizure, what education you give about? It's all about safety. It's all about, clearing the area out, putting the head of the bed down, turning them on their side in case they vomit, side rails up, and calling for help, right? What type of seizure is when the body is jerking, they're foaming at the mouth, and the child is rendered unconscious? They've changed the names of this since I was in nursing school, from Petit Mal to Grand Mal. Now we've got different names. So when you're actively jerking and foaming, that is a tonic-clonic. Again, what sort of teaching are we going to give these parents or caregivers? Again, safety, safety. A child that has seizures, you wouldn't let go into a pond, a lake, and a pool with nobody around. What if they had a seizure in the middle of the water? They would go under, and that'd be the end of them. So again, you got to be careful with seizures in children and adults. What notable sign may indicate increased intracranial pressure in an infant? You can walk into a newborn nursery and you might have one child who has some sort of, central nervous system, something going on there. This is a child when they cry. It's like nails on a chalkboard. They're up an octave. It's this high pitched crying, extremely distinctive. Okay. They're going to have a fontanelle, not crying, at rest, sitting up, will be bulging. Okay. And that's the part of it. Not when crying, just normal, they bulge. All of the following increase intracranial pressure except what? Now, if you're taking care of a child with a head injury, these are things you need to know. So you can have a child that's tachycardic and it doesn't really make a difference. If they are going bradycardic, this is end stage, late stage, too much intracranial pressure on that child, okay? Tachycardia doesn't bother them. Too much fluid, coughing, suctioning, anything like that can increase that intracranial pressure. So if we had to suction, it would be gently and it wouldn't be often. It would be as infrequent as we possibly could. What findings can alert you to a head injury that's getting worse? I mean, many times we get a lot of sports injuries where they slid into third base and the head hit a knee and they were rendered unconscious there. So they bring him in to be checked out. Coach says, no, he was knocked out. Please go get him checked. The one thing that you hear is, was I safe? Did I get out? Was I safe? And they're going to ask that question over and over. It's that change in orientation, a change in level of consciousness. It's that asking that same question over and over again because they don't remember. That is the first thing that you see, is that change in mentation. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? When we see a fixed and dilated pupil, that means it's not reactive. That means there's a problem going on, swelling inside the brain, an absolute neurological emergency. If we don't relieve that pressure, it's going to be brainstem damage, and they're going to be at a lower level when they were before that injury. It is a lot of pressure causes a lot of neurological damage. You see this a lot. I worked in the ER the last 10 years of my career, and I worked in a very high level trauma center. So we would get a lot of kids. I can think of one fall off the second story on, to the ground and came in with a helicopter. And when they arrive, first thing medical team always does is they look at the pupils to see, hey, are we already dilated or are we still reactive? And they know really how to work really quick. So one of the first things we check neurologically on head injuries, pupils. What medication may be used for a child with cerebral edema due to fall? So cerebral edema, head with too much fluid in it. What diuretic would be appropriate for the brain? And it's mannitol. Furosemide is peripheral edema, that's pulmonary edema, specific to brain, mannitol. Okay? Febrile seizures usually occur in what age child? So febrile seizures usually start when they're very young, and somewhere about age 6, children will just grow out of it. Now, what are febrile seizures? Febrile seizures are when a child is no fever and 20 minutes later they're 101. It is how quick it got up that high, which sparks something in the brain and creates that seizure. And they are tonic-clonic. They are quite aggressive looking seizures. And it's due to basically the fever went up too quick. Childhood hypopituitarism results in what condition? Remember, there's two pituitary conditions. One is fluid and one is growth. Hypo means what? And that's the answer. And that's pituitary dwarfism. It means you're not grown enough. That means you're short. And that could be a great example of a hypopituitarism. How would you describe precocious puberty? Precocious puberty is when a boy or a girl goes into puberty too quick. What's the problem with that? Well, if you're 6 years old and you're a girl and you're getting breasts and you're getting your menses and all of that, it's just not normal. And it could create problems, with people teasing, et cetera, right? Also, males can also precocious puberty, getting a beard at a younger age, growing hair where you shouldn't. All of those things we want to suppress until when they're supposed to go through puberty. A multi. What lab values are important to monitor with a child with congenital hypothyroidism? So hypothyroidism, and we're going to be giving replacements, right, in order to keep that child getting the growth and the height and weight that they should. But we'll be monitoring T3, T4, TSH. Growth hormone has nothing to do with the thyroid. That is the pituitary gland. And cortisol is the adrenal gland. So what do we look for? Thyroid, T3, T4, TSH. How can you monitor a child with hypo or hyperthyroidism? I mean, how do you know if the medication's working, that they're getting what they need? How do you know? So when you're looking about thyroid, again, with children, what's the one thing that's different? It's all about growth, right? So how do you monitor it? We do it all the time. Height and weight that we do every visit. Are they gaining weight? Are they losing weight? Are they getting taller? Are they not getting taller? All those things could point to a thyroid gland that's not being treated properly. Maybe they need a different medicine. Maybe they need more of what they're getting, but we do monitor it through height and weight. Very simple. What acid base alteration would you see in a diabetic child with Kussmaul respirations? What is Kussmaul respiration? When we have a child in DKA, diabetic ketoacidosis, the body goes into an acidotic state. But the body is really cool, and it really tries to compensate it for it. So what it does, it puts yourself into a respiratory alkalosis with those puffy breaths that sort of trying to blow off this acid. So the acid base you would see with Kussmaul is the alkalosis, but the acid base of the body is that diabetic metabolic acidosis. It's trying to compensate. It's trying to get it back to normal. That's why you go to Kussmaul, not because you're about to die or to go out. It's to try to help the body. A multi. What would a child with Cushing syndrome look like? So Cushing syndrome is a little bit tricky because these children, big round face, red, ruddy cheeks. It's like these red, sort of smushy looking face on the cheeks. You're going to have more hair, acne. You're going to have fat on the trunk and face, but your extremities, because of protein wasting and whatnot that goes with it, you're going to have thin arms, thin legs because of those muscles not being so plump as they should be. Okay. What drugs are used for nocturnal enuresis, bedtime wetting? And I put this in here because the same drugs are used for diabetes insipidus. It's desmopressin, vasopressin. So, how would you know that the drug worked if I had bedtime wetting? Simple. I stopped wetting the bed at night, right? Which information will the nurse include when teaching a patient about thyroid replacement therapy? So, your child is hypothyroidism and they need to get a replacement. You need to teach them. So, what are you going to teach? So, make sure they take it in the morning. They take it at night, they'll be awake all night long. It's they get the thyroid hormone gives them a little bit of boost, like a little energy boost, I call it. It's like when you talk to some women, they say, "Yeah, I'm a little pudgy because I have a hypoactive thyroid gland," right? So give a little bit of that thyroid hormone and it speeds them up and helps them lose weight. So if you think of it that way, you can't give it at night. They'll be awake all night long. And it has to be on an empty stomach before meals in the morning. And then you've got your boost for the day to be able to go on and have that energy. Because part of thyroid problems is that lack of energy with hypothyroidism. A multi. You walk into a child's room with fever 104.6 and are having a seizure. What do you do? So check the bed, turn them to the side rails up, have suction at the bedside, not to put in the mouth, but maybe if they vomit around where their mouth is, laying down there, maybe get an IV in. They might need some medications if the seizures doesn't stop. You might have to call the doctor, right? Those are other things that you might see when you have a child with a seizure. Autoimmune disease of the thyroid gland. This is usually girls in that pre-adolescent stage that we determine something's going on here. The thing about this disease, it's autoimmune. That means these children are immunosuppressed. You can't do surgery. These children will live on replacements of whatever thyroid hormone is missing. It is called Hashimoto. Addison's disease, that's an adrenal disease. Addison's. If Cushing's, Addison's. Opposite of each other. What's Addison's? So this is when you don't have enough. Cushing's too much, Addison's not enough. And this is cortisol and aldosterone. You see Addison's disease, if the baby's born with this, these children will have ambiguous genitalia. This is part of Addison's disease, and these children will be on cortisol, aldosterone treatments for life after we figure out are they a male or a female, because we don't know by the sex organs. They're a little bit of both that you'll see. A multi, a ventricular peritoneal shunt. The ventricular peritoneal shunt is a tube, a catheter that goes up into the fourth ventricle of the brain, behind the ear, down the neck, front of the chest, and into the peritoneal cavity. It is used for hydrocephalus, too much fluid, and for some reason itself can't get the fluid out. So this tube helps it. Now, behind the ear, there is a bulge, and you see it there, and it's actually a little pump. We do not touch that at all. Only the neurosurgeon can fix that pump, touch it, and do whatever with it. How do we monitor a ventricular peritoneal shunt? Well, head circumferences. It's going to tell you, is that fluid going away or is it getting bigger? Is the shunt working? And that is with head circumference. A common sign of Graves' disease includes blank or protrusion of the eyes. And this is with hyperthyroidism. It's also called Graves' disease. They got some great commercials out about this right now. It's for medication, eye drops to help this exophthalmos, these big bulgy eyeballs. It's called exophthalmos and it is a side effect of Graves' disease or hyperthyroidism. A multi. What are signs of hyperparathyroidism? There's a bunch of different things to try to keep straight in this last exam. So the parathyroid gland, what does that do? So the parathyroid gland has to do with calcium regulation. So when you have too much calcium, it causes nausea, vomiting, confusion. Remember, calcium, magnesium both work with muscle strength. You know, whether too much strength or not enough strength. So when you have too much calcium, you go that to almost to numbing because it's just so stiff. It's just too much muscles going on there. And it causes that paresthesia or that numbness in your extremities. It is hypercalciuminemia. What does the parathyroid hormone do? And it regulates calcium. The parathyroid's all about calcium. When you think of calcium, magnesium, they all have to do with muscles, whether they're contraction strong or it's not contracting well enough at all. A multi. Hypoparathyroidism has the symptoms of technic muscle contraction and hypo, not enough calcium. Do you see the difference? Yeah, hyper too much, you're to the point of paresthesia, numbness, because there's just too much spasm going on. Hypo, there's not enough, right? That's where you're going to see that weakness. It's just floppy. I can't use them, right? And hypoparathyroid, it means low calcium, simple, low calcium levels. Which of the following may be a cause of an adrenal crisis or Addisonian crisis is the other name? What does the adrenal gland, what is it mostly you think about? We've already talked cortisol and aldosterone. So what would cause an adrenal crisis? An abrupt withdrawal from steroids. This is when you're on steroids for a long period of time, you don't taper them off, and you go into this absolute adrenal crisis, hypertension, chest pain, shortness of breath. And how do you treat an Addisonian crisis? Give a steroid, get the level back up, and then wean it off and taper slowly. A multi. A cardinal sign of diabetes insipidus. Pick it out now. Explain why it is what it is. Which ones are they? So, who put polyphagia? That's diabetes mellitus because you can't digest sugar and you're still hungry. So you keep eating to try to get sugar, but your body's not digesting it. You're not getting sugar. So you keep eating because you're not getting it. Diabetes insipidus is pituitary, which has fluid balance. That's it. I'm thirsty and I'm urinating. Polydipsia, polyuria. And you're not going to have a big urinary output, are you? Absolutely. Huge, not decreased. A multi. Congenital adrenal hypoplasia parent teaching should include. This is that child that adrenal gland is not getting what it wants, or Addison disease. I quickly mentioned it as I was talking about it. Adrenal. Remember, when you talk adrenals, you're talking cortisol, you're talking aldosterone. This is a child who was born, I've only seen one in my career, and they had a testicular sac and they had a vagina and a prominent clitoris. How do they assign a gender? Well, in this case, they did testing, x-rays, ultrasounds, seeing what body parts were there, etc., and then made a decision and made that child whatever they decided, boy or girl. They will never have children. They don't have all the proper parts. Okay. And because it's a problem of not enough adrenal hormones, we need to give cortisol and aldosterone replacements. And these will be increased from stress and infection and all those things. So, congenital adrenal hypoplasia is that sex assignment that you have to do. What causes type 1 diabetes? Eating too much sugar? So type 1 diabetes, again, is the body cannot digest sugar. It is a destruction of the beta cells in the pancreas that are destroyed through an autoimmune process. This is an autoimmune disease. You're immunosuppressed with diabetes. Which statement about a pheochromocytoma is correct? This is actually another adrenal tumor. It's a tumor on the adrenal gland. Now, pheochromocytoma is actually very difficult to diagnose because they come in complaining of elevated heart rate and chest pain and shortness of breath. So you think it's cardiac. Well, what happens with pheochromocytoma, the adrenal glands secretes this sympathetic or, everything up, up, up type of elevated heart rate, elevated blood pressure. This like an epinephrine is secreted and it creates everything to go up. But it just happens for a second and then goes away. So again, they go through all of this testing and then they finally say, oh, let's check. And they find a tumor on the adrenal gland. Preoperatively, these are children that you must be monitoring their vital signs to see, especially if they start complaining of feeling that chest pain or tightness, etc. Check the heart rate, check the blood pressure, see what's going on because you have this hormone that's being secreted that's making everything elevated. A multi. What action should the nurse implement in the care of a patient with a pheochromocytoma? So again, pheochromocytoma secretes this sympathetic, like an epinephrine, which makes the body everything elevated, heart rate, blood pressure, and that's all we're going to monitor. has nothing to do with blood sugar. It's the adrenal gland. And it has nothing to do with fluid balance. It's the adrenal gland, cortisol, aldosterone. A multi. Nursing care of the unconscious child include. Now, if you're unconscious, the care would be is again, you're going to see why are they unconscious? Is it because of a fall, etc.? You're going to do those neuro checks, seeing if they're alert. What do the pupils look like? Vital signs are always important. We start seeing blood pressure, heart rate going up. They could be in pain, and then we would do our pain control with it. Temperature, very important. That could tell us why an elevated heart rate or why you're so vasodilated and why blood pressures are low. And of course, intake output cerebral always you have to be very good not to overload them with fluids. What might you suspect if a child feels jittery, sweaty, and is dizzy? What do you think's happening? So this is basically hypoglycemia. You have a child that's not, all of that shaky and jittery stuff. You can probably think it's hypoglycemic. What's treatment if they have low blood sugar? Well, give them a glass of orange juice, a glass of milk. Give them a teaspoon of honey if they're at least a year old, right? There's little things that we can do in order to get that blood sugar up until we get that proper meal with protein in it, et cetera, et cetera. Symptoms of DKA are, well, what happens in DKA? So the body stops being able to break down carbohydrates and use sugar, but you're still eating. You're still eating all this sugar. So blood sugars go elevated, 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 elevated. And you become, with blood sugars, I've seen up to over 1,000. I think 1,003 was the big one that I did see. So then your body says, all right, blood sugar, I can't eat carbohydrates. I don't understand. So let me eat proteins. Let me eat fats. Byproducts are ketones. So now you've got a child full of sugar, so you even smell like it. They're breathing sugar. Their blood sugars are so elevated. And, these children's blood sugars, as I said, 600, 800, 1,000, and you'll be positive blood sugar, positive sugar in your urine, 4+ ketones in the urine also. These kids usually come in fruity breath that smells like a rotten peach that's been in a Tupperware container in the refrigerator for a month. And you open it up and you get that sickening sweet smell. That's what DKA smells like. I won't die. An adolescent has a BMI above 95% and they've been urinating a lot. What tests do you think they might run on that child? What do you think is going on here? Well, this could possibly be diabetes. So, yeah, absolutely. We're going to be doing a hemoglobin A1C. Let's look at the last 2 to 3 months of blood sugar and see if it's elevated. In a child, it would be 7 and above. In adults, it's lower, 6 when you're that type 2 that first start to look at it, that pre-diabetes. In children's a little higher, it's 7. Also, you're urinating a lot. Is it a urinary tract infection? And you're getting rid of a lot of, electrolytes, so let's check them. Diabetic ketoacidosis is caused by what? So, diabetic ketoacidosis is caused by your body not having enough insulin to digest carbohydrates and goes to proteins and fats to be able to eat and breaking them down. As simple as that. A multi. A child's admitted with a blood sugar greater than 600 and large ketones in the urine. What is your priority intervention? You're in DKA. What's your priority? What are you anticipating first? So we are going to be giving a bolus of normal saline. Number one, what does that do? If I have a big blood sugar and I bolus it, at least I'm going to get that blood sugar down a little bit, right? Also, and they usually come in dehydrated to boot because they're vomiting because they don't feel very well. And we're going to have them on a regular insulin drip and we'll titrate that according to blood sugars. Our priority is not electrolytes. Our priority is that fluid and insulin, get the blood sugar down. Then we worry about electrolytes. A diabetic child complains of feeling jittery and the blood sugar is 45. What's the best treatment for the child? When you get these questions, the key thing to look at is, are they awake or are they unconscious? This is a complaining child. They're awake. Give them orange juice. As simple as that. Okay. You're not going to recheck it. None of that. If you see a blood sugar is low, they're jittery, just go ahead. Orange juice, milk, teaspoon honey, whatever you've got there full of sugar. Your patient has experienced a head injury. What would most concern you? I'm getting pressure in the head. I've got an injury in there. What's really here? Something's going on. So in the head is your pituitary gland, right? Swelling could occur, could squish on it and decrease urinary output. And that would be sometimes the only thing that you see. How do you decrease that energy and that swelling? Mannitol. Let's get that swelling down so that we can get our urinary output back up where it needs to go. A multi. How do you detect diabetic ketoacidosis? So, how do you detect it? They have elevated blood sugar, 4+ ketones, 4+ glucose in the urine. Are they dehydrated? Well, most of them are, but how do you detect diabetic ketoacidosis? It's the sugars, it's the ketone, it's the glucose in the urine. A multi. What would alert you that a child's head injury is deteriorating? So think about a head injury. What's going on? You get the head injury, you hit your head, some swelling starts occurring, and more swelling starts over time happening. So they become confused, they become restless, they become difficult to arouse. We know that change in LOC is one of the big things. And then a headache that's getting worse. So it's a headache, and now it's worse, maybe even waking up from sleep. Sort of similar to a brain tumor about how it gets worse over time. What is the primary cause of injury associated with submersion? Drowning. What's our big thing about drowning? And remember, these children, even though they're awake and alert and skipping by the time ambulance comes, if they were underwater and we had to resuscitate them at all, these children have a big chance of going into respiratory distress syndrome. They must be in a hospital for 3 days because it's up to 72 hours later they can show things. And what happens is water gets in there, gets in the lung, and they become hypoxic. And that damages the lung and that makes them susceptible to going into respiratory distress. It's from the hypoxia. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? What do you do first? What's your most important thing? You have a child with bacterial meningitis. I mean, any of those answers could be correct. What's priority? Antibiotics. Absolutely antibiotics, because that meninges is full of infection and you're in droplet, type of isolation, and we need to start those antibiotics. 24 hours later, we could take them off isolation, but they are extremely dangerous for the patient and for others. So we need to get antibiotics in. Priority. To identify whether the cause of meningitis is viral or bacterial, what do you do? What do you obtain? What would show you the difference? So when we do a spinal tap, we're going to be looking for certain things. I know if I do a spinal tap and I see that the liquid that's coming out, this cerebral spinal fluid, is clear, it's a viral. When it's a little cloudy, that's the white blood cells. And the white blood cells are going to show us that, this is a bacterial thing. Also, there's another thing. Bacteria loves sugar. So your glucose level will be low and it doesn't like protein. So that would be elevated in your cerebral spinal fluid when they do the test. Double points. Precautions for bacterial meningitis is and it is droplet. I know that's a tricky one. People want airborne, but no, it is droplet. Which medication is used for those with increased intracranial pressure to rapidly reduce the pressure? Yes, I did ask it before. I am making sure you know it. And it is mannitol. Good job. A traumatic brain injury is what? We see this in children. They can fall off of, the changing table and beds and tables and couches and how many times they roll over. It happens actually quite a bit. You'd be surprised. And it's basically damage to the brain due to a sudden force to the head. I fell down and bopped my head on the ground, right? That is a traumatic brain injury. A multi. Symptoms of traumatic brain injury in an infant. What do you see? I used to get a lot of infants in that are about 6 months old. Now they're rolling and they didn't realize it, rolled off the change table and hit the floor. What am I looking for? Well, first of all, I'm looking for the, increased intracranial pressure, which showed bulging fontanelle, distended neck veins. It would be that cry, right? And later on in this traumatic brain injury, because of the pressure that's in there, we're also going to see bradycardia. That's when it's getting really scary. You don't see tachycardia. And last question, a multi. Which CSF lab results correlate with bacterial meningitis diagnosis? So, bacteria like sugar. I've already told you the answer, but let's go over it again. Bacteria love sugar, so yum, 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 low glucose. And there was usually you should be about 60. I think it's about 20 when you see it on the numbers. Elevated protein. It says, yuck, protein, I don't like you. So that level is up. You'll see increased white blood cells in there. Red blood cells you shouldn't see unless they've nicked a capillary on the way in. Well, let's see how we did today. Lizzie, good job, Lizzie. Number two. Jay, number one. Who won? Drum roll. Bing. Val. Good job, Val. Four. An ET. ET go home. We're going home. Mariah. Good job, guys. I will be sending this out to Dr. Becker for you all to have this recording, so don't worry, you will be getting it. Anybody who needs anything more from me, please just reach out to me. I'm always here to help you. Does anybody have any questions, comments, concerns about anything? Well, it's been a pleasure. You guys have a great afternoon. Take care.
Thank you.
My pleasure.
Thank you.